Okay, welcome everyone. So the goal of today's, discussion will really be centered around the whole aspect of what we call sometimes post-capillary pulmonary hypertension. And I do think that in neonatology, there's a few opportunities to kind of uncover this phenotype in different conditions. I think one of them that we see sometimes is congenital diaphragmatic hernia, which I know, for example, Sofia works in Argentina, Will works in Philadelphia, and they do see a lot of these patients, and they may have some of these mixed phenotypes that may have a component of post-capillary pulmonary hypertension. So we'll try to kind of deconstruct these concepts. So I'll start because I like to make it interactive. I'll start by asking what is for you guys, and that's a very easy question. I think I've asked this question 25,000 times. What is for you guys the definition of pulmonary hypertension? Anyone? How do you define for you pulmonary hypertension? I deconstructed the three words. Anyone wants to jump into it?
An elevation of pulmonary arterial pressures, oftentimes leading to right ventricular strain. But yeah, elevated PA pressures.
Okay, very good. So very simple, high pulmonary pressure. So pulmonary hypertension means within the pulmonary compartment, hyper means elevated, tension means blood pressure. And we know that the blood pressure is a function of flow times resistance. And typically we talk about a gradient of pressure will be dependent on your flow times your resistance or your RV cardiac output or the pulmonary flow or pulmonary blood flow, which may be dependent on RV output plus or minus other sources of blood flow, times the pulmonary vascular resistance, knowing that the pulmonary vascular resistance may have a component that is dynamic or fixed. And we talk about fixed pulmonary vascular resistance when, for example, there is progressive obliteration of the arterial tree. So we see that often in conditions like idiopathic pulmonary arterial hypertension or familial pulmonary arterial hypertension. These are more like conditions that we'll typically see in the pediatric world, but there are very rare genetic condition that may give a similar phenotype in the early neonatal period. So we'll talk sometimes about situations like a disease called TBX4 or a disease like, even trisomy 21 can sometimes present like this, where they actually get fixed vascular either obliteration, so disappearance of pulmonary vascular structure. And so you diminish your pulmonary vascular surface area. We think sometimes, grossly like pulmonary hypoplasia, which have less alveoli, less vascular surface area, and because you have a fixed component. So no matter how many pulmonary vasodilators you're going to introduce in that context, you've kind of vasodilated your 2-3 alveoli, like they're done, they're already vasodilated. So, and you're trying to fit that flow or cardiac output within the context of this limited space. So resistance, flow, and we often talk about a delta pressure or, a gradient of pressure. So we'll often look at the pressure within the pulmonary arterial compartment relative to what's happening at the level of the distal drainage area. And what we'll be talking about today is how this distal area, which is the drainage pressure, can impact on the upstream pressure measurements. And so after the age of 3 months, we do have certain cutoffs of number that have been established as a community of practitioner to tell us, if I put a little catheter in the pulmonary artery and I measure pressure and I measure a systolic diastolic curve and I actually do an area under the curve and I obtain a mean pulmonary arterial pressure, we do have cutoffs of what we would consider at sea level to be abnormal compared to normal. Would anyone know what are these like international standards of cutoffs of metrics that would be considered abnormal?
For
Sophia,
which
you're muted.
for which value specifically are you referring to, Gab?
So let's say what would be the metric that is a standard internationally to say this patient has pulmonary hypertension after the age of 3 months of age at sea level?
Yeah, I mean, PAP is above 20
More than 20. No?
Which PAP? Because we often have a systolic, a diastolic, and a mean.
Yeah, the mean?
Yes. So when we go to the cath lab, we obtain a systolic, we obtain a diastolic, and we actually obtain an arterial curve in the pulmonary artery. We can even get one in the LPA and the RPA. And that is particularly important if we think that there's distal obstruction, or if we think that there's like, an LPA or an RPA stenosis. But theoretically, if there's no stenosis and all the pressure will equalize across the entire pulmonary vascular arterial tree, you will get the similar tracing across the pulmonary vascular tree on the arterial compartment, and you'll get a systolic, a diastolic, and the area under that curve will provide you a mean. And if you're looking at the international guidelines, whether they're North American or European, after the age of 3 months, the value of 20 is the cutoff to say this patient has pulmonary hypertension if their mean pulmonary arterial pressure is above 20 millimeters of mercury. And then you have to decide whether it is because you have a component of increased reactivity to the vascular bed, increased PVR. Do you have a component of increased flow, like flow lesions, like shunts? Or do you have a component of both? Or do you have as well a component of distal obstruction? So we used to use the concept of what we call post-capillary pulmonary hypertension, in the idea that it is the obstruction or the anomaly sits distal to the capillary bed. If you look at the World Health Organization, they're going kind of away of this terminology. They're actually talking about grouping of pulmonary hypertension. We'll go into that. But I think what's important is to understand the whole path of where the RBCs are going throughout your lungs and what could actually be influencing your pulmonary pressures, because that's what you're going to be measuring at the cath lab or trying to estimate using your echometrics. Does that make sense up to now? Okay, perfect. Let me just open some graphics, so that's going to be more useful. I need to put it by order. This. Okay, so we said mean pulmonary arterial pressure starting the age of 3 months. What's happening below 3 months? Like, do we have cutoffs? What are, normal values? What would we use? Anyone?
Would you try to just maybe compare to systemic?
Yes, actually. And why is that? Could you explain?
I would. The presence of shunts is get more prevalent in that age group.
Okay, so there is a component for sure of the shunting that is you have persistent fetal shunts that may influence your physiology, and but I think really the reason why we haven't defined specific cutoffs of like numbers, it's because there is a huge dynamic changes in the transitional period in terms of your PVR and SVR ratio. The other thing that I do want to bring to your attention is that a vascular structure has a tendency to be extremely dynamic. And while they have a tendency to speak with each other, like all these vessels, they also have a component of autoregulation. So you may have differential pulmonary vascular resistances and differential flow distribution and differential venous drainage capacity depending on different territories within your lungs. And so areas of the lungs may compensate for other areas that may be severely impacted. So just to be aware, if you're treating a patient with BPD, we've seen patients with, for example, 1 vein, 2 vein, pulmonary vein stenosis, pulmonary vein atresia, and other veins that are actually preserved and the flow being redistributed in some of these areas because there is distal obstruction in some of these other lobes that are quite diseased. There's also a huge interaction at the alveolar surface area where obviously areas that are well oxygenated and well ventilated or well recruited will have a capacity to typically better vasodilate than areas that are, of course, under-recruited, under-ventilated, et cetera. So this is very dynamic, and although that we would want to take the whole lung as a whole block and say, like, this is what's happening to the entire lung, the disease that we see in neonatology are often multifactorial and affecting areas of the lungs quite differently. And just to keep in mind that the vasculature of the lung is not just like arteries, there's veins, there are capillaries in between, and there's a whole network of lymphs also that, you know, some of these diseases like Noonan and rhizopathies may also influence, because they influence the drainage capacity of these alveoli, which can translate into, you know, alveolar exudation and hypoxia and vascular constriction, which you can then get a secondary type of pulmonary hypertension because of that. So I'll share my screen for 2 seconds. Let me just pull up my slide. Hopefully, okay. Use slideshow. So there's a few things I want to talk about today and a few goals I want to go over. I don't have any conflict of interest. Except I do get some funds from Mallinckrodt to support unrestrictedly the Neocardio Lab, but hopefully it won't influence what I'm going to tell today. So we just said pulmonary hypertension is usually a measure of high blood pressure in the pulmonary artery. I do think that the word hypertension is a bit of a misnomer when it comes to neonatology, because we have situation where the pressure in the pulmonary artery may actually drop very low, paradoxically, but there's extremely high resistance. So I'll give you an example. Let's say the afterload is so bad that your right ventricle is dying and it's not even able to generate output. Or let's say you have situation like Epstein anomaly, which some of them may have extremely high PVR and they actually may end up in this physiology of circular shunt. If you go and would measure their pulmonary artery pressure, the pulmonary artery pressure may start dropping once the flow starts dropping and once there's less flow into this pulmonary artery, despite the fact that resistance is very high. So when we say it's high blood pressure when the RV is able to still cope and generate flow. But once you're at the extreme of this pulmonary hypertension crisis where the PVR has been so high and you've been so hypoxic and acidotic that your RV is not functioning anymore and you're not generating output, then your pressure may actually be paradoxically low because you're in a very low cardiac output state. And this is often like a pre-mortem stage, unless you have like shunts and ability to actually bypass and offload some of these situations for the RV that's failing. Okay, so in the first 3 months of age, you get a dramatic change in your pulmonary vascular bed. You get dynamic changes in your systemic vascular resistance, in your pulmonary vascular resistance. And typically by the age of 3 months, you should get blood pressure around 15/5. So systolic of 15, 5 of diastolic with a mean of around 10 in your pulmonary artery. But as you're doing these changes, you can see how your mean PAP may still be high or higher than 20 just because the pulmonary vascular bed is still relaxing. So that's one concept that's important to remember, is that actually below 3 months of age, we don't really have a number that tells us, oh, this is like pulmonary hypertension. What we'll often use is the relationship between what's happening in the pulmonary vascular compartment compared to the systemic vascular compartment. So for example, if I have a patient that's in front of me at the age of 3 days old, where I would expect that the PVR are already in that zone that are lower than SVR, and I have a duct that's restrictive and completely right to left with systemic blood pressure that are kind of expected for the gestational age, then clearly your PVR are higher than your SVR. And that's really like the reverse relationship of what I would be expecting. So that's very clear for pretty much everyone, is in the consensus of saying, well, that situation, it seems to be quite out of the ordinary. And knowing that you have higher PVR than SVR in the context where I expect these SVR to not be abnormal, because again, it's a ratio. So you always have to look at numerator to denominator. If your denominator is within normal, which means your SVR, you're not expecting them to be abnormally low, and you're shunting right to left, then there's clearly suprasystemic PVR in an abnormal range. So I think we've been over before the idea that each time you look at a ratio, so septal motion, shunt direction through a post-tricuspid shunt, you always have to look at what's happening in the systemic compartment compared to the pulmonary compartment. So of course, a kid who has an E. coli sepsis where SVR are extremely low and the patient is extremely hypotensive because of that, and you have a complete right to left PDA, well, yeah, your PVR may be higher than your SVR, but it doesn't mean your PVR are abnormally high. It just means your SVR are abnormally low. So it's important to keep in mind these ratios when you're addressing like what you think to be pulmonary hypertension, because the end result of pulmonary hypertension, or the end result of having excessive afterload to the RV, is exactly what Will mentioned, is that eventually you get excessive strain to this very vulnerable ventricle, the RV, which is poorly or quite intolerant to high afterload. And if the RV has no way to pop off, it will eventually fail. And because it's failing, first of all, you get poor output to your pulmonary vascular bed, which means that your LA is underfilled, you underfill your LV, and eventually you have poor output on the systemic side. Unless you have pop-offs, so unless you have shunts, so if you have a large PDA, your PDA may actually equalize pressures on both sides. And so by definition, you'll have an RV that has systemic pressure, but your baby will be very blue because a lot of the flow is actually bypassing into the systemic compartment. Or if you're in a situation where the PDA is not there or it's becoming restricted, your RV will start facing higher and higher afterload, especially if the cause is high PVR. And eventually your RV will remodel, will have very high filling pressures. And because they're high filling pressures, the right atrium will be exposed to this RV that is poorly compliant. And if you have a large ASD, you'll be able to pop off through that ASD right to left, have a baby that's very blue preductally. And again, at least maintaining the preload to the LV through this shunt, but reducing significantly your pulmonary blood flow or UQP to QS. And so these babies are blue, but that, it's better to be blue than to be completely gray. Because if you wouldn't have these shunts and your RV would be severely failing, what you would see is a very balloon right atrium that is very under pressure and a lot of retrograde flow in these SVC, IVC, subhepatic veins, and massive livers, and these babies that are ascites and, actually going into a low cardiac output stage. So the benefit of being a newborn is that we actually have these shunts that are typically open or that are openable in certain contexts. And so that may help us in some of these PH etiologies. So the actual definition of what we call pulmonary arterial hypertension, it's better to, there we go. It's definitely better to be blue than gray. The definition is this mean pulmonary arterial pressure above 20 millimeters of mercury. We'll typically speak about arterial when we think that this is primarily a condition that is affecting the arterial side. It's a bit of a misnomer because it's always in the pulmonary artery that the pressure rises, right? But then when we say arterial hypertension, it means that we think the primary mechanism is through either a vasoconstriction of the pulmonary arterial bed, or that there's actually an insult or injury to the arterial bed that is rising this pressure, and it's not something that's coming from a distal obstruction to the drainage of the venous system. So how would we express this in metrics if we would go to the cath lab is typically in pediatric, we would get what we call a pulmonary arterial wedge pressure or LV and diastolic pressure that is less than 15, that allows nicely the drainage from the pulmonary venous system eventually into the LA and eventually to the LV. And we'll see where there's some caveats that we have to think about based on the etiology. And of course, there are different ways of calculating the PVR, but typically we'll speak about, PVR index. So index the body surface area, a 3 Woods unit times meter square, telling us that the PVRs are increased, either because they're vasoconstricted or because they're obliterated by fibrous tissue, or because there's pulmonary hypoplasia and there's not enough pulmonary arteries. And so they're actually being overwhelmed by the cardiac output. And typically that there's a diastolic transpulmonary gradient of 7 between what's happening on the arterial side versus the venous side. So if I go quickly, because I want to speak about the idea of post-tricuspid. When we talk about post-tricuspid, it's because we mean that there's a component of drainage concern. So you have your sorry, you have your LV, you have your aorta is providing blood flow to your tissue will eventually drain in capillary bed, which will eventually drain into venous system. And this venous system in the majority of population that have normal cardiac configuration will drain into an IVC and an SVC, eventually into a right atrium. There are exceptions where there's no IVC and a zygous continuation and all these things, but, principally it's draining into the right atrium. The right atrium will then feed preload into your right ventricle, which will eventually eject in your pulmonary artery, sending blood flow into the pulmonary vascular tree via arterioles, eventually capillaries, eventually draining into pulmonary veins. There's different configuration of pulmonary veins, but the most typical is 4 or 5 pulmonary veins coming back to your left atrium. So as soon as you get an issue along the path of the drainage system, so kind of your sink draining everything from the tap, everything will kind of backflow. And you can think of, if you backflow and if you start having higher pressures because of this backflow, like the highway is blocked because all of the exits are blocked. So we laugh because in Montreal, if you've been to Montreal, the nightmare of the highways, because traffic is a disaster. And often it's a disaster because of construction and because of, immense traffic. And basically, and I think it's the problem of all big cities, that you get on the highway and it's nice because you're happy, it's like flowing, and boom, suddenly it's like a parking. And why it's a parking? It's because distally it's blocked. It's not because the actual highway has 3 lines blocked. They typically keep all these beautiful lines open and they decide to block all these exits. And it's like, figure it out. So that's kind of the concept of congestion. Now, the element about the lung that's quite magic is that, as I just said, it's a dynamic organ. And knowing that it's a dynamic organ is that these vessels will adapt to avoid having excessive pressure or trying to constrict. So you can, what I'm trying to say is that in some of these patients with post-capillary pulmonary hypertension, you may have reactive mechanisms that will actually lead to a component of pulmonary vasoconstriction. But the primary issue is often an issue of drainage, although some conditions may have a mixed picture. And often we'll talk about these mixed pulmonary hypertension mechanisms. So let's say you see a patient and you suspect that the primary etiology causing increased pulmonary arterial pressure is related to a component of congestion within the lung because of this issue of drainage. What could be, first of all, some mechanisms in a newborn that would cause this? Anyone? What could be etiologies?
Like issues in the left atrium, so increase in left atrial pressures, LV diastolic dysfunction leading to elevated LA pressures.
Hypoxic encephalopathy with left ventricular dysfunction.
Okay, that's
Like
great.
a PDA
Yeah, so if you have,
significant.
like, for example, I'll give you an example. Let's say you're a patient who was born at 25 weeks from a pregnancy complicated by extremely severe preeclampsia. And because of the preeclampsia, you had a placenta that had extremely high systemic vascular resistances because of the placental dysfunction and insufficiency. And one of the secondary effects of that is that they often have very high resistances. And we often see these umbilical arterial flow having absent end diastolic flow. We see pulsatility happening in this pulmonary and the umbilical venous Dopplers. And what happens physiologically in these IUGR fetuses is that you're actually vasoconstricting the pulmonary vascular bed, which is supposed to be a very low vascular resistance. So it's like taking an ECMO oxygenator and increasing the SVR on it like crazy, right? So what happens is that your aorta, which is connected to the umbilical artery, suddenly faces very high resistance, which in part will expose both ventricle to increase afterload, because both ventricle have a large PDA in fetal life, which allows for this equalization of pressure across the two arteries. So now the RV and the LV are facing as well. So they're facing this high PVR system, but now they're going to also face this higher SVR system. So that can lead to some biventricular remodeling and adaptation because it increases the afterload. But one thing that's quite interesting is that by increasing the resistances of the placenta, you're actually increasing the resistance or the afterload that the aorta is facing, which will reduce some of that transductal flow from right to left in fetal life, because this right to left depends on very low resistance into the aorta. So then because you're reducing this transductal flow, you're forcing a bit more flow through your pulmonary vascular bed, which eventually will increase your preload into your LA, which by increasing preload in the LA, you reduce a bit the transforamen flow from right to left, because no matter what, your preload in your LA will rise a bit. So you're increasing preload to your LV like this. So you have a higher afterload, higher preload to your LV, which will remodel these LVs. And some of these patients actually are born with some degree of LV hypertrophy and stiffness. So if you take a preemie who's born at 25-week, 400 grams, who already has this a bit stiffer left ventricle, and then suddenly you open the gate of this massive duct and you flood these lungs and you have tons of pulmonary blood flow coming back to the LA, and the LA has this inability to drain nicely into compliant LV because the LV is not compliant anymore. Well, no matter what, this LV will become, this LA will start to become very dilated. And unless you have a nice interatrial shunt to decompress this LA, you'll have an LA that's under hypertension, and you can eventually cause problem with venous drainage. So that's just one example of the extreme of something that we could see in some of our patient population to explain why some patients with ducts will appear with this white lung, a lot of pulmonary edema, and others would have beautiful, like large ducts, left or right unrestricted. You look at their x-ray and it looks completely fine. They're on CPAP 21% and they don't have backflow pulmonary edema. So etiologies, there's many. I usually look at the different steps of the way of where could be an obstruction. So of course you can have what we call, one of the diseases called pulmonary venous occlusive disease of the newborn, very rare condition, very bad condition, has been kind of described in the literature as uniformly kind of fatal. Although who knows, maybe there's like kids around the world that have received a transplant in their lungs and they're fine and they're just not published, or maybe they've been published and I'm not just aware. But that's a very bad disease of patients who present in severe hypoxic rest failure. They have a phenotype of post-capillary hypertension, they have white-out lungs, and it's really a disease of how the venous structure are actually formed at the level of the lungs. And sometimes we pick it up either by cath or we pick it up on biopsy or on autopsy after mortality, unfortunately. Very rare. Then you have anything along the drainage system, which could be a problem. So pulmonary veins. So your veins could be either stenotic, atretic, they could be uniformly obstructed, or it could be segmental obstruction. So we see some of our preterm babies, very rarely, those with BPD pulmonary hypertension can actually develop some of these pulmonary venous phenotype. We think it's related to inflammation, fibrosis. Maybe some people are saying it's related to transductal flow. It's been reported to be associated with necrotizing enterocolitis. But again, it's a rare entity and it seems to be progressive. And there's a lot of different literature about this particular entity, and we'll try to talk about it a bit towards the end. But uniformly, what it gives this later presentation of patients who do have some degree of high pulmonary artery pressure, and you start seeing these veins that are becoming very accelerated on echo, or by MRI, CT scan, you see that there's narrowing of the caliber. And one thing about echo is that it's very good to pick up acceleration, but if you have pulmonary vein atresia, there's just no flow, you might not pick it up. So that's one concept that's important to remember, is that if you don't have any flow through a pulmonary vein because it's completely obstructed, it's very easy to miss that by echo because you just don't see the flow. And also because these lungs are often abnormal, so if there's already low flow through that territory, but there's also a pulmonary vein obstruction, you might not see the acceleration if there's no high flow upstream because there's been redistribution. So sometimes we can miss that by echo. And so if you have a concern or if clinically the patient presents such as post-capillary pulmonary hypertension in a kid with prematurity and pulmonary hypertension, then, low index of suspicion to go to cath lab, to go to CT scan, MRI, to actually try to evaluate these pulmonary venous drainage system. And one of the key clinical findings you would find is a patient that when you give oxygen, you start pulmonary vasodilators, or you do intervention to drop these pulmonary arterial pressure, they actually deteriorate and they start developing like massive pulmonary edema, pulmonary effusions, whiteout of the lungs. That's very unusual for a kid who has a strictly pulmonary arterial hypertension, where it's like more of a PVR phenotype. So that would be like kind of some of these ominous signs that would make you suspect, there might be something related to the drainage issue. One very common, well, not common, but one of the very, congenital heart defect that we do see in our clinical practice that will present as the extreme example of pulmonary hypertension secondary to venous obstruction is TAPVR obstructed. So if you've never seen a TAPVR obstructed, they will present with this kind of whiteout lung because there is obstruction to the venous drainage. Let me just share again sections that I wish you pay attention to. Going to go here. So I've put here the website. In the TN echo section, there's a whole section on pulmonary hypertension. I think whoever's going to do, either the fellowship or interest in hemodynamics, it's a very good section to go over. There's a lot of content, some of the definition, the group, and all these things. But one thing that I do go over are the different criteria to talk about this combination of pre and post-cap, or isolated post-cap or pre-cap pH, which are kind of definition that's been standardized throughout the different pulmonary hypertension meetings throughout the years. And I do go over also the groupings that I hope we're going to be able to talk about, which is the language that today is kind of recommended to use. So the group 1 being this pulmonary arterial hypertension phenotype, which in the newborn would be like something like acute pH, PPHN, these kind of diseases that are heritable, that are increasing PVR. And when we talk about group 2 is really this kind of post-capillary or left-sided heart conditions. And then group 3 is anything that's related typically to lung disease. So in adults, it's like COPD, smoking, cystic fibrosis. In babies, we'll often categorize BPD in group 3, although BPD, we realize that is actually a multifactorial condition. They have probably a component of all of these kind of factors depending on the lung issue. So TAPVR, if you go in the section on congenital heart and you go in total, not transposition, you go in total anomalous pulmonary return, that's definitely a disease that absolutely needs to be recognized immediately if you're going to be involved in a kid that's critically ill and that's blue at the bedside. If you're thinking PPHN, pulmonary hypertension, the one thing you need to evaluate is, could that be TAPVR that's been mixed? Because if it is, you need to call cardiology, cardiac surgery immediately, because these patients, there's nothing you can do medically. You just need to bring them to the OR because they're obstructing, right? So the typical obstructed lesion are the infradiaphragmatic TAPVR, which means that the entire venous return comes back via what we call sometimes a vertical vein. It's a bit of a misnomer, but vertical vein, because it's not always vertical. And it goes into either the ductus venosus or eventually to the IVC. And the kinking through the diaphragm, as well as the actual obstruction of the ductus venosus, which will actually constrict eventually after birth, will create this kind of situation of post-capillary pulmonary hypertension. And these patients will have like whiteout of the lungs. I do think that I have an X-ray somewhere on one of the presentations of Caroline. Yeah, we often talk about this Snowman sign because they get so much edema in their lungs. Do I have another X-ray? No. So that's one very, classic etiology of post-capillary pulmonary hypertension. Let me stop sharing and go back to my graph. So where else could I have the drainage? So we said the vein could be an issue. So if I have a venous drainage issue, okay, let's say I would put a catheter. So what would be increased actually? Which pressure would be increased? Or maybe I should go back one step. What's a pulmonary arterial wedge pressure and what's a left ventricular end diastolic pressure?
Endostolic in the left ventricular.
Okay. So it means the actual diastolic pressure, which is supposed to be very low, right? And diastole, the LV expands, the pressure drops, the mitral valve opens, then you get your LA, which has built up preload during the entire systole of the cardiac cycle, will gush blood flow into your LV gets filled, and eventually the pressure rises during contraction at the time of isovolumetric contraction time. And during that time, mitral valve is obviously closed, and eventually pressure is so high that it actually overcomes the diastolic pressure into the aorta and ejects and creates that systolic pressure. And the systolic pressure in the aorta will equalize with the systolic pressure in the LV until you get a drop in pressure inside your LV, and eventually you close your aortic valve, your LV continue to expand, and if it's very compliant, the pressure will drop often near like 1 or 2 or 3 millimeters of mercury, and then your mitral valve will open, right? And then the cycle restarts. So the pressure in diastole into the LV are supposed to be very low. They're supposed to be between like that 1 to 3 to 4 millimeters of mercury. And so you start seeing increase in this pressure in diastole when either you have a distal obstruction to that, or you have properties of the myocardium that are inherently causing issue to this relaxation. So it could be the myocardium or extrathoracic, extracardiac. So you can have, for example, a tamponade that's going to really increase pressure around the heart and prevent this heart from actually expanding and dropping intracardiac pressure. So that's like the extreme example of diastolic dysfunction of the LV. You can have endofibroelastosis, like secondary to maternal lupus inflammation. You can have cardiomyopathy, like restrictive hypertrophic cardiomyopathy, even dilated cardiomyopathy, which will make this ventricle to have very high filling pressure. And so if your LV and diastolic pressure is high and you don't have issue to your mitral valve system, your LV and diastolic pressure will equalize with your LA. And so your LA pressure will be high, which by definition, your pulmonary venous pressure will be high. So what I do when I do a pulmonary artery wedge pressure is that I actually take my catheter, I go into the pulmonary artery, and I block either segmental arteries or the main pulmonary artery, and I actually measure distal to that, what's the pressure that's residual. And so we assume that the venous pressure in the lungs will be the same as the LA pressure and the same as the LV and diastolic pressure, but it's not always true. Because if I have an obstruction here, my capillary wedge pressure will be very high, but my LA pressure will be very low, actually, because you have low preload to your LA. So if I do an echo on a patient that I suspect there is a component of post-capillary hypertension, and I see a completely right to left interatrial shunt, it's either that I have a TAPVR, for example, so all my flow is coming back to the RA and the LA is completely underfilled. So I have high post-capillary wedge pressure because my pulmonary vascular bed is obstructed, but my LA pressure is actually very low. So that's just conceptual, right? If I have pulmonary vein stenosis or atresia, same thing. I'll have very high post-capillary wedge pressure, but my LD pressure may be very low, and my baby may actually be blue because of a right to left shunt here. Now, if the condition that's causing high capillary wedge pressure is at the mitral valve level, so for example, severe mitral valve stenosis, the kid had mitral valve endocarditis, or in the pediatric world, they can see sometimes rheumatic heart disease or mitral valve regurgitation that's very severe, Schoen complex, abnormal attachment of the mitral valve, parachute mitral valve, diseases like, for example, if you have patients with AV, so AV septal defect, and then they're, in AV septal defect, they have a common atrioventricular valve, and they often have left-sided leaflets and right-sided leaflets, and sometimes you can have imbalanced AVSDs, and this imbalance can have like very small left-sided cavity, and because of that, after repair, sometimes they can have disproportionately small LVs that has, poor compliance, and some of these patients may actually develop LA hypertension because of that. So when you're seeing a patient and you suspect, based on your clinical findings, which is patient deteriorating in the context of, high PA pressure on your echo. So, RV looks, under high pressure, you have a flat septal curve or a right to left septal curve, like bone septal curve in systole, you have a high TR. So you're getting a sense that this RV is under hypertension. And then when you're looking at the overall picture, it's a kid who has like this whiteout of the lung or pulmonary edema, or when you give oxygen, they're worsening, or when you're giving pulmonary vasodilators, they're developing pleural effusion, things like that. These are things to think about. Oh, there could be a post-capillary phenomenon. Then you have to look at all these areas. Do I have hypertrophy to my left heart? What's happening to my interatrial shunt? What's happening to my pulmonary venous drainage? So if I have a patient that has a strict left to right interatrial shunt, I would be surprised that this patient has 4 pulmonary vein severe stenosis. Because if you have 4 pulmonary vein severe stenosis, your LE preload should be significantly reduced. And as such, your LV preload will be reduced. And in these contexts, often if you do have an ASD, which at that point often they won't, or the ASD will be extremely tiny because they're older, you either will have a bidirectional or right to left shunt at that level. So that's kind of an indirect sign. Although it's not foolproof, it's an indirect sign that goes with the physiology. Does that make sense? So when I look at post-capillary pulmonary hypertension, I look pulmonary venous drainage. Could there be anomaly there? I look at my left atrium. Is it that I have mitral valve disease? Is it that I have a situation of a small LV, uncompliant left ventricle? Is the issue downstream at the level of the LV or the LV outflow tract? So we see many functional diseases that can impact the LV relaxation, some of which are rapidly addressable, tamponade, some of which are not rapidly addressable, so patients with significant hypertrophy. So Pompe disease is one that comes usually later, typically at 2 to 3 months of age. Patients exposed to very high dose steroids that have significant LV hypertrophy, infant diabetic mothers that can have like significant LV hypertrophy, which can impair relaxation, LV cardiomyopathies. All of these diseases can eventually impact your left atrial filling pressure, your LV filling pressure, left atrial filling pressure, and then backstream into your lungs. And so as you're increasing pulmonary blood flow because the PVR are dropping, they may not be able to compensate. And the extreme example is when we see these patients with hypoplastic left heart syndromes that actually have very small left ventricles, and they have maybe an ASD that is restrictive, and then you start dropping your PVR, increasing pulmonary blood flow, the blood flow comes back to the LA and has nowhere to go to. And that, these kids are extremely ill, very rapidly, they go into a low cardiac output state because you're not able to eventually even feed your right atrium to go into the RV to feed the pulmonary artery, and then eventually use the duct to feed your aorta because it's blocked at this level, right? So that's kind of the extreme and congenital heart defect. Everything is clear up to now because it's been 48 minutes that I've been blah-blahing.
Yes, is the same that the same case in the CDH. Like
so
you have a small left ventricle sometimes, and the ventricular interdependence. So maybe it's the same like hypoplasia ventricular.
Yeah, it's fascinating in CDH because I think we're still trying to understand why some of these patients are having a component of left ventricular involvement. And what's the degree of the left ventricular involvement? And is it a component of only systolic problem or diastolic problem? Could it be leading to LA hypertension or not? And of course, the minute you have an ASD or an interatrial shunt, if it's small and your LA starts having higher pressure, well, you won't be able to decompress your LA, right? So then your LA might be rising. And one of the things you could do by echo, actually, you can use Doppler to look at the velocity through that interatrial shunt and get a sense of the relationship between the LA and the RA. Again, important to remember that when you look at these velocities, it's the relationship between the two structures. Now, in CDH, we also know the CDH population of patients may have some degree of exposure to high PVR, pulmonary hypoplasia, pulmonary vascular constriction, acidosis, all these things. And because of that, their RE pressure may be higher. And actually, some centers may even will put you umbilical lines or central catheters, and they'll measure the central venous pressure. And you'll see like central venous pressure informs you, of course, on your preload, but also informs you on what's happening in terms of your filling pressures, right? So if you're going to have high RV filling pressure, your jugular venous pressure, your RE pressure will start rising. So if I do an echo and I see a completely left to right interatrial shunt, and I get a mean gradient through it of 7 or 10, which is very high, and my RE pressure is about like 10 already, then your LE pressure is about 20. But let's assume that you have a RE pressure of like 15. And you have this, little left to right PFO shunt, and you get a velocity, and the estimated gradient by Bernoulli tells you there's like 2 millimeters of mercury of difference. If you don't know what's happening on your RE side, you'll say, oh, the LA-RE, like the velocity through the PFO is not so impressive. Like, I don't care,
Yes.
right? Like, it's not LA hypertension, but you could be fooled, right? You could be fooled. So that's why it's important to take what you see on the echo, what you see on the PFO, and try to put the pieces together. I like to do these. I like to actually take these graphs and put the numbers, put the shunts, try to understand what are my SATs, what are my blood pressure, what's happening to my lungs, what do I see on my x-ray, to try to decipher a bit, like what's my phenotype. And most of the time, it's going to be quite obvious on echo, but it's more in these more subtle patients, more subtle physiologies that, putting together all the boxes and trying to understand, okay, what's the problem? What's my SVR? What do I expect to be my SVR, my PVR? What are surrogate measure I can use to actually assume that? So if I'm at bedside and I see a patient that is profoundly gray with a refill of 7 seconds and has an E. coli sepsis, and I'm like, oh, I'm gonna like blast norepinephrine at this baby because I think this baby needs more SVR support. Well, I would tell you probably the SVR are very constricted right now. Maybe there's something else that's happening. Maybe we need to look at what's happening with the flow. Maybe we need to know what's happening at the level of the cardiac output. Is it contractility issue? Am I on like a mean airway pressure of 25 so that my LE, my LV is completely underfilled? And so I need to drop my mean airway pressure to favor actually filling in my LE. So it's kind of these things that you'll use these pieces of the puzzle, including the echo, to inform kind of these boxes to then decide how you're going to be doing the care of these patients. I do want to give a brief overview of what we know and the challenges related to pulmonary vein stenosis, because I think there's a lot of new knowledge that's coming out and a lot of unknowns about pulmonary vein stenosis. I've done a section here which contains a few elements. What we would see so the typical pulmonary venous Doppler, first I'll start with that because I think it's important to recognize what a normal pulmonary venous Doppler looks like. So in babies, fortunately, you can obtain Dopplers of the pulmonary veins in multiple views. For example, in the apical view, you can get some of the upper and left-sided pulmonary veins in most patients. In the subcostal view, you can see many of the pulmonary veins. A very classic view, because you get to see most of the pulmonary venous drainage coming back to the left atrium, is what we call the crab view, which is typically a view we obtain in the area of the suprasternal zone, a bit on the left sometimes, because you're going to try to trigger kind of your view towards your left atrium. And it does look like these kind of, little crab arms that are coming, the arms and foot of the crab that are coming into the left atrium. And so venous flow will have a tendency to have a low velocity, a low speed. Of course, if I have no pulmonary blood flow, example, I have extremely severe pulmonary vasoconstriction, and I'm unloading completely my pulmonary artery, or I have no output in my pulmonary artery, I'm not going to expect to see that much velocity in my pulmonary vascular bed just because there's just no flow through it. So that's one thing to keep in mind, number one. Number two, if you're going to start opening the tap with like massive left to right shunts, you're going to increase so much the pulmonary blood flow that eventually these velocities will start rising because there's just torrential, it's like Niagara Fall that I'm trying to funnel through a little like hole, you know? Veins are stretchable to a certain capacity. So these velocity will be modulated to the degree of how much you can stretch them. But at some point you will get acceleration if you get this kind of funnel effect. So that's why with PDAs, we'll often see these different velocities start getting much higher. So that's one thing we look when we look at PDA physiology. So if you look here in the section left to right PDA, and you go into the pulmonary venous flow here, you can see how you get these different velocities. So typically the beginning are the S velocity just after the QRS, and then you get a diastolic velocity. Diastolic velocity means what? It means the mitral valve has opened. So the gates are open. So then suddenly everything that has accumulated into these pulmonary veins are gushing through into the LA and into the LV, because now the LA is able to empty somewhere. So everything that has accumulated in these veins are able to actually accelerate. So this is an acceleration of speed. So often in very significant left to right shunts through the duct, these patients may start accelerating their D velocity. So you have S1, S2, D velocity, and then your atrial area. And then S1, S2, D velocity, and then atrial area. We'll talk sometimes about the fact that during the atrial contraction, which you can see is just before the P wave, you'll get a bit of retrograde flow in this pulmonary venous Doppler. That's not necessarily abnormal. It's when you start having excessive duration of that or very high velocity in terms of flow coming back to your pulmonary vein that you start being concerned that there's a bit more LA hypertension. So that's one indirect sign that we would look for if we think that there's downstream like LA hypertension. Example of a PDA that's causing massive LA dilation. So if you have, of course, too much flow or mitral valve disease or LV diastolic dysfunction, your LA may start dilating as a kind of surrogate of that. And so there are metrics. We often use the LA on aorta, but you can imagine if this LA is able to offload completely into the RA, the LA will not dilate. So that's how dynamic the heart is and how beautiful what we do, you know, to try to understand these different things. One last thing I want to show you here is this example here. This is actually a view from the parasternal where the LA has dilated so much that you get flow coming from the LA into the RA in this posterior view. So this is the right ventricle. You get the tricuspid valve, you get the interinsural wall, and actually it's LA that's dilated quite significantly. And you see almost this flame at a very high Nyquist or high velocity. So that means that whatever is here is higher than 104 centimeters per second. It's quite high a velocity. So it tells me that from the LA to the RA, there's a relatively high velocity restrictive interatrial shunt. And if you trace that interatrial shunt, this informs you that your mean gradient throughout your cardiac cycle, so from QRS to QRS, is about 8.5 millimeters of mercury. And so if you assume that your RA pressure is normal pressure, which is around 3 to 5, it tells you that in average, you have about 10 to 12 millimeters of mercury in your LA pressure, which is higher than what we would expect. Okay, and a peak gradient, which means what peak gradient? The peak gradient velocity, translated in Bernoulli, tells you that between the LA and the RA, there's about 14 millimeters of mercury. When does the peak gradient appear? Is when the mitral valve and tricuspid valve are closed and your LA and your RA are being filled. So that's typically when? That's typically during ventricular systole. So QRS, the ventricles are emptying. During that time, the atriums are filling. And so at the peak of the filling of these atriums, you get a gradient of 14 millimeters of mercury. And we know that at that peak pressure, the RA pressure, if it's a normal pressure, would be around 5. So you're reaching up to like 20 millimeters of mercury of LE pressure. So no wonder that some of these babies who have large ducts will get this pulmonary edema and congestion. Because if your lung would be an organ that you can take and empty into the void and start pumping Niagara Falls through it, if you're able to drain everything, the highway is draining, there's no problem. It's when you start having issues with these exits that are actually causing like upstream congestion. And that's often the issues with these preterm, is that some of them may have hypertrophy, ventricular stiffness, left ventricular dysfunction, and in the context of this large PDA may start getting some of these symptoms. So just to keep in mind. I know it's 3 p.m. Am I allowed another like 3 minutes? You're like, we need to like get away from this crazy guy. So I just want to finish because we were going through these pulmonary venous Dopplers. So pulmonary venous Doppler are typically low velocity, triphasic, biphasic. They correspond to, the systolic, diastolic flow of the cardiac cycle. So you'll see the different Doppler depending if it's the right upper, the left upper, the right lower, the left lower pulmonary veins. And so you have beautiful examples here that you can see how these Dopplers would look like. When you accelerate because of too much flow, typically you don't lose this physicity. You maintain these physicity. So that's why in PDA, which has this very high left to right shunt and high QPQS, so sometimes you need to generate 3 pulmonary blood flow to maintain 1 systemic blood flow, like QPQS 3:1. Your velocities will be very high, but you're not going to lose these different physicity because the vein is actually wide open throughout the entire cardiac cycle. You start losing phasic flow when there's an obstruction, when you start having restrictiveness of your conduit. We see it with the PDA, for example. So the PDA that is very large is going to have this pulsatile appearance. The minute it starts to become restrictive, which means that it's not allowing the flow to pass freely, you start losing this pulsatile pattern and you start becoming more of that kind of sawtooth pattern, these higher velocity throughout the cardiac cycle. Why? Because upstream pressure is building up. So it's the concept of a water hose. Where's my water hose? Somewhere here. That if it's open freely, you're just emptying. But if you start putting and pinching the tip, you build up pressure and then velocities are going to be very high. It's pretty much the same concept almost for pulmonary vein stenosis. Is that pulmonary vein stenosis, you see here high velocity and you see this continuous high velocity flow. And if I Doppler it, I actually have lost this nice physicity to it. So in patients who have nice flow going to certain segments of the lungs, but have distal obstruction because of pulmonary vein stenosis, you'll start seeing these indirect phenomenons. Okay. And while echo is great to recognize that the Doppler is abnormal and that there's high velocity, it's also great to miss the fact that there are veins that are either stenosed because there's not enough flow upstream to create this acceleration, or it's great to miss the extreme case, which is pulmonary atresia, pulmonary vein atresia. So that's really kind of the dreadful diagnosis that can be missed often and for which you would need complementary. But the role of the clinician is to recognize that the clinical picture is, first of all, the picture of a patient who have increased pulmonary arterial pressure, downstream RV effect, and that the picture does not correspond to the usual classical pulmonary arterial disease where there's high expected PVR that would actually improve with adequate ventilation, oxygenation, and sometimes some of these pulmonary vasodilators to drop pulmonary vascular resistances. And actually these patients worsen when we start some of these medication. The caveat is that in some disease with pulmonary vein stenosis, some areas of the lungs may actually have high arterial tone. And you will see certain PH practitioners that will say, well, in situation where the patient is extremely sick and we're under ICU monitoring, some of them may choose to actually trial out some of these oxygen pulmonary vasodilators to see, am I able to rescue the blood flow to other territories and try to decongest the areas that are actually obstructed. But I would say in order to actually trial out these things, it's like multidisciplinary discussion, status of the patient, ruling out that you're not going to decompensate your patient. And so there's a lot of like subtleties to doing that. And often these patients will go to the cath lab and will probably have some attempts to decongest some of these veins. More and more people, will attempt either interventions to actually put stents or drug-eluting stents. And now there's like inflammatory modulation that is becoming also an element of the treatment. So there's many articles, for example, using sirolimus, some of them using steroids, some using tyrosine kinase inhibitors and VEGF antagonists to try to help remodel the velocity. But as you can see, the end result is often these right ventricles that are facing this progressively high afterload, which might be actually a combination of arterial and venous disease. And while this current ventricle is able to contract, you can clearly see that it has, to some degree, adapted, whether or not it's maladaptive or not. There's clearly hypertrophy, and you can see this LV that looks underfilled, and an RA that looks definitely more generous than this LA that is probably underfilled as well. So we could go on and on to talk about every single diagnosis that is causing pulmonary venous congestion. But I think what's important is to recognize that it's multiple entities. And when you see a patient with what you feel to be high pulmonary vascular pressure, you need to deconstruct it. You need to look at what's the flow, what's the resistance, what's my distal drainage, what are each of these components before you just jump into knee jerks. Oh, I'm going to give, sildenafil, I'm going to give INO, I'm going to give these pulmonary vasodilators, because actually you may worsen your patient if you don't go through the exercise of looking at these different components. Okay, so sorry, I'm on service, perfect. But in pulmonary vein stenosis, the problem is in the S wave, right? Not the D wave. So in pulmonary vein stenosis, it's a good question because you can catch pulmonary vein stenosis at different degree of the stenosis. What typically happens is that as you become more and more stenotic, you start accelerating all your flow, all your venous flow, but you lose the physicity. You actually lose it.
Okay.
But because your LA becomes hypotensive, it actually exacerbates the signs of kind of acceleration, right? Because your LA is underfilled. Unless your LV is also problematic and you have fibrosis of your LV. And so that's where the diagram becomes quite important to put like, oh, hypertrophy, I expect high LV and diastolic pressure. LE is big, but why is the LE big? Is it because I have too much flow through it? Is it because I have, obstruction to my drainage? Is it because, a large PDA? What's happening to my pulmonary veins? Do I see constriction, acceleration? Did I have clinical symptoms that I have pulmonary edema that is segmental? So of course, if it's segmental always, it would be weird that it's secondary to it would be weird that it's secondary to like LA hypertension, secondary to LV and diastolic pressure increase, right? If it's always the right upper lobe that becomes completely wide out, then you start suspecting that it's drainage of right upper lobe that's a problem. But, of course, these vessels are dynamic and they redistribute. So many of these patients will go to either cath lab or CT scan or MRI to get a bit more information on their venous drainage system. Okay, 308, I spoke too much. Question, comments, insults, was this useful, not useful? There's no question. Don't log off right away. Any questions? Come on, I'm sure.